Hello and welcome to the third and final video in our series on using the ultrasound for assessing knee OA. In the first video, we went through kind of the basics of OA and some of the recent literature. In the second video, we talked about the ultrasound scanner and fundamentally how does it work and how do we use it. In this video, we're going to try to put those two things together and talk about specifically using the ultrasound to help us assess knee OA. Once again, this project was generously supported by BD Health and administered by the ICUNJ. We thank both of them for their generous support. Now, let's get into it. Now, I personally am an exercise science professor. I am not really a trained medical professional, but I do a fair amount of probably unhealthy dabbling in assessing orthopedic injuries. And I've always used the HOPS algorithm, very common in athletic training. So the HOPS stands for history, observation, palpation, special tests. Basically asking questions about past events and subjective experiences, using your eyes to sort of see any visual evidence of the injury or orthopedic condition you're assessing. Palpation means actually putting your hands on the patient to see what you can assess. And then special tests, in this case, we'll be using the ultrasound as our special test. So the basic idea here is we are trying to gather as much information as we can about the risk factors a person might have, about the symptoms they might be experiencing, and then try to get some sort of visual look at their knee cartilage to see if these things all converge on a common answer. So we always start with history, talking to the patient, to the client. We'll start by asking them their age, gender, height, and weight. Age and gender obviously are risk factors. Female gender, age over 50. Height and weight allow you to calculate BMI. And remember, a BMI over 24 is considered another risk factor. Most of us, you're probably familiar with BMI as a kilogram per meter square. But, if you're just asking people their height and weight, they're probably going to give you pounds and feet. So it's always good to remember you could calculate BMI as a person's weight in pounds divided by their height in inches square, and then multiply the whole thing by 703. That will give you the same BMI measure. And that way you don't have to go about converting to meters and kilograms. Once you've got those out of the way, we're going to ask some questions. Have you ever injured your knee? Does your knee ever hurt? Does your knee feel stiff? And if so, when does it feel stiff? A lot of people with knee OA will sort of report it feels stiff in the morning when they first wake up, usually for an hour or so. Does it ever feel like your knee grinds or crackles when you move it? That's basically the description of crepitus. And you might be tempted to just ask your patient, "Hey, do you ever experience crepitus?" But many patients are not going to know what you're talking about if you say that. It's better to ask them, did your knees feel like they grind or crackle? They're going to understand what that means much more likely. Now, there isn't a whole lot that you can directly see with regard to knee OA, but there is one risk factor that you can sort of assess just by observing, and that is genu varum, or as it's more commonly called, bow-leggedness. This is a known risk factor for medial compartment knee OA, so knee OA on the medial side of the knees. And the way you would observe this is you just have the person stand up with their feet together and you observe how far apart are their knees. Now, a lot of sources I read say that your knees should be able to touch when you're standing with your feet together. And for me personally, when I stand up with my feet together, my knees do touch. I've done this with a lot of classes though, and it's always shocks me like how few people in the room are like me. Most people's knees don't appear to touch. They always have a little separation of them. So always think about this a little bit as a spectrum, right? Some people get pretty close But some people, look like they've been riding a horse their whole life. They just have these crazy big bow legs. If somebody puts their feet together and stands comfortably and their knees are a mile apart, that's a pretty high degree of genu varum, and that's another potential risk factor for knee OA. So when it's time to palpate, we're going to have the patient lie supine on an operating table or an exam table. Always remember to ask before you start touching people. Tell them what you're going to do and why you're doing it. Never just sort of assume it's okay to start touching people. So I would let the person know, okay, I'm going to feel around your kneecap and around the joint space of your knee. Is that okay? If they say it is okay, then you say, okay, let me know if something hurts. And it's not a bad idea to also just kind of keep an eye on their face and their facial expression while you do this as well, because some people are a little reluctant to say something hurts, but if you're poking, especially a really sore spot, you can usually tell it hurts by the look on their face. So, like I said, we're going to try to feel around the kneecap and around the joint space between the tibia and the femur. It's always a little more distal than you think. It can be kind of hard to find. So just kind of poke around the whole area, see if anything hurts. If it does, that's bony tenderness. That's another one of those important risk factors for knee OA. Now it's time for the ultrasound image. So there's a couple different ways you might go about doing it. This is a slightly simplified version, but I think it shows us probably the best information that we're going to get with an ultrasound with regard to knee OA. So while the person's still lying supine on the table, you essentially have them flex their knee as much as is comfortable, usually at least 90 degrees. If they're able to go a little farther, that's good too. And we're going to try to scan sort of three regions, this sort of trochlear surface, notch of the femur up here around where the one is, particularly in the short axis. You can tell a few important things from the long axis view, but kind of the best views are the short axis views. That's what these images are about up here. More about those in a second. And then also in the long axis, trying to get the medial femoral condyle and the lateral femoral condyle. You won't always be able to get the lateral condyle because in a lot of people, when they flex their knee, the patella slides laterally and it covers the condyle. So you might not be able to observe the lateral condyle. If you can't, that's usually not a big deal because most OA is on the medial side. And most people, it's not too hard to find their medial cartilage. These images up here, these are actually my knees, if you're wondering. I scanned these myself. Our scanner isn't quite big enough to get the entire sulcus, so you'd see it's in two images. I had it slid over to the lateral side, made sure to label it right, lateral TS for trochlear sulcus. And then it lets you measure the thicknesses of the cartilage in different places. So this is measuring the thickness sort of at the lateral edge of that sulcus. Here's the right medial side, measuring thickness over here at the medial edge as well. So you can measure thicknesses of the cartilage and we can compare them to what we knew from the previous video. In the middle of that sulcus, it should be about 3 millimeters, at taper down to closer to 2 millimeters on the medial and lateral side. And then when you look on the condyles, it should be roughly 2 millimeters there as well. But you can also take it a step further and grade cartilage. Now, this grading scale comes from Cow et al. From the Journal of Orthopedic Surgery and Research in 2018. They basically have grades 0 through 4. 0 is normal cartilage. Sort of the characteristics of normal cartilage is that you have, very anechoic cartilage itself with very smooth margins, so that surface of the bone, sort of where the cartilage meets the bone, is pretty hypoechoic, and it's a nice smooth line. Likewise, the sort of more superficial surface of the cartilage makes a nice smooth line with the tissue above it. So that is a grade 0, and all the thicknesses are, about what they should be. Keep in mind, smaller people might have thinner cartilage, larger people might have thicker cartilage, but it'll be in the ballpark of what is normal. Grade 1 down here, this is what I would personally give my cartilage on the previous slide, is basically normal, but the margins get a little blurred, or perhaps the cartilage itself lacks clarity. So you'll notice the difference between the grade 0 image and the grade 1 image is mostly that these lines, instead of being nice and sharp, they start to get a little fuzzy. And you'll see, like, instead of it being very, very anechoic through here, it gets a little bit gray through here. But if you measure the thicknesses, they're all about what they should be. There's no real obvious defect here. This is just the very early stages of a little wear and tear, probably fairly common with age. It's very likely this person doesn't feel any symptoms even. Like I said, I would grade my knees personally as a grade 1, and I don't feel any symptoms, at least not yet, knock on wood. All right, grade 2, this is abnormal cartilage with blurred margins, lack of clarity, and overt thinning to, not as much as 50%. So kind of like before, the margins are not as sharp. There's some grayish in here, some graying in the space that should be anechoic. You'll notice here there's some kind of obvious defect on one spot. I don't know exactly what this is, but you can tell it's not normal. And then if you measure these thicknesses, they're probably in the ballpark of half of what they should be. So instead of being 2 millimeters, maybe this is 1.1, 1.2 millimeters, something like that. It's definitely thinner than it should be, and you're starting to see all the other changes as well. Grade 3, it just continues this trend. Now the thinning is more than 50%. So the basic bone cartilage interface is still more or less intact, but now the thicknesses are down to less than a millimeter in places where they should be 2 millimeters. And then grade 4, the severely abnormal cartilage, this is where you start to get places where there just is no more cartilage. You can kind of see right here, here's the bone, here's the space above it, over here, there's a little anechoic space. It looks like there's cartilage there, but it's just gone from this part where there should be cartilage. So this is another useful thing. When we go through the images, you can measure the thicknesses, but you can also look at the quality of the image and give it this grade 0, 1, 2, 3, or 4 based on the quality of the image you see. All right, so that sort of concludes the data gathering. Now putting it all together, what are you going to tell the patient? Well, remember, we're not really professionals here. We're not diagnosing anything, but we can put together what we see and sort of present it in a way that helps inform, what the patient should do next. So, basically, we're taking an inventory of risk factors, symptoms, and signs. So when you talk to them and you ask them about their knee history, height and weight, observed genuvarum, how many of these risk factors do they have? Likewise, how many symptoms do they have? Do they have knee pain? Do they have the tenderness when you palpate, the creaking feeling when they move their knee, or bad stiffness in the morning? How many of these signs do they have? And then how many of the signs that we can measure with the ultrasound, thinning cartilage, osteophytes, those places where the bone is starting to protrude into the space where the cartilage should be, or just disruptions in that bone cartilage surface. How many places of grade 3 or 4 cartilage did we find? And obviously, the more signs that a person has, the greater their risk might be. For example, you're probably going to see a lot of females over the age of 50 with a BMI greater than 24. But if they don't have any symptoms and their cartilage all looks like it's a grade 1 or better, they probably pretty low risk for osteoarthritis. On the other hand, you might have somebody in their 40s with a good BMI, but if they have knee pain and crepitus, or stiffness and crepitus, and when you look in the ultrasound, you see a lot of areas of grade 2 or grade 3 with some obvious osteophytes, that's a person who's at a pretty high risk. A word of caution, and this comes kind of directly from this the same Cow et al. Article I referenced earlier. There'll be a link to where to find that in the description of the video as well. Is that the overall accuracy of ultrasound for diagnosing knee OA by trained professionals was about 75%. And they actually did this in this particular study by taking, I want to say it was a large number, 100 or more, maybe it was 200 people who came in complaining of knee pain, and they assessed everybody with an MRI, with an ultrasound, and then also with an arthroscope. And they kind of used the arthroscope as the final say of whether or not you had knee OA was based on the arthroscope. So the interesting finding about this was that ultrasound and MRI were actually about equally correct, and that was about 75%. And in this study, false positives were fairly rare, but false negatives were common, right? A lot of people looked fine, but actually weren't fine. So remember, the thing I would caution you about is the flip side of this statement here, right? Trained professionals get it wrong about 25% of the time using the ultrasound. And we are not yet trained professionals. Someday I hope some of you will be. But for right now, always keep in mind that your assessment might be slightly off. And so if anybody does come to the clinic with particularly a lot of the risk factors and they're experiencing the symptoms, even if you don't really see much in the ultrasound, it's still good to encourage them to talk to the doctor about their knees and the possibility of getting a further screening for knee OA. So that is my final word here on the subject. Thank you for watching these 3 videos. Hope you learned a lot, and I hope to see you soon to get you a chance to have some hands-on practice with the Clarius ultrasound. And so maybe you can start down this journey of learning more about this device as well.